أنا اسمي أحمد حلاق. أنا كارديولوجي فيلو بأشنر نيو أورلينز لويزيانا. وقبل ما أبلش الفيلوشيب عملت سنة بالهارت ترانسبلانت and advanced heart failure. قبلها كمان عملت سنة بالفاسكولار ميديسن. قبل هيك كنت في تكساس تك، وقبل هيك كنت في الإمارات درست في جامعة الشارقة. شكرا على اللي دعوني، لأن أنا كتير سعيد جدا إني عم أعطي هالمحاضرة. يعني حتكون this is going to be about 30 to 45-minute lecture. Right heart catheterization. If there's anything that was misunderstood, please stop me and we can go in depth and explain. Tamam? So we'll start with the patient. Our patient is a 79-year-old female that was sent from the internal medicine clinic to the emergency department. Her symptoms: dyspnea on exertion. She also had leg edema and anasarca on exam with weight gain. And 3 weeks ago, she was active and had no symptoms at all. Her past medical history: diabetes, well controlled, chronic kidney disease, hypothyroidism, and hypertension. So she went to the emergency room, and her vitals, she was a little bit hypertensive. She was sitting 93% on room air. And on exam, she had an elevated JVD, lower extremity edema, anasarca. Her chest X-ray, as you can see on the right. Her BNP was 1,700. Her troponin was 24. This is the high sensitivity troponin, so the cutoff for normal is like 12 or 13. So very mildly elevated troponin. Sodium was 134. BUN 43. Creatinine was 1.4, and everything else was pretty normal. So as of now, what are the differential diagnoses for this patient? Number one, you're thinking about heart failure, صح? You've got the elevated JVD, you've got the lower extremity edema, you've got the elevated BNP. So realistically, number one, you're going to be thinking about heart failure. So other differentials in this patient, you got to consider pulmonary embolism, acute coronary syndrome, and renal failure. So what's the next step for this patient? هلا عفوا، بس اتأكد نحن جاهزين نبلش ولا منتظرين حدا؟
نحن معك دكتور.
تمام. المهم so differential diagnosis on this patient، يعني هذول اللي حنفكر فيهم طبعا. So what's the next thing that you do in this patient? So عادة نحن لو جانا واحد هيك, next thing we're going to do is get an echo. Well, this was the echo that we got on this patient. There's a few things that you can see. بدي أرجع لهون. So we call, this is the D sign. You can see a little bit of pericardial effusion. You can see a very large right ventricle. Left ventricular.
تمام. عم تتمشى مع PE.
تمشي مع الPE صح. That's a good point. There's one sign on PE that is quite. There's a couple things that you need to consider. In PE, there's two types of PE. There's acute and there's chronic. There's an echo finding on PE that goes more with acute, and I'm blanking on the name of the sign, but it's when you see the apex of the right ventricle is contracting where the rest of it is down, and this patient didn't have this. So look at this echo finding. You can see the TR velocity was 4.67. So this gives you an RVSP of 87 plus the CVP, and it was a dilated IVC. فحسبنا the CVP is 15. In addition to 87, so this person has a PA pressure of 102. So in a patient with a PA pressure of 102, if you take a normal person and they get a PE, and their RV has to go from doing normally 20 millimeters of mercury to 25 millimeters of mercury, and now their pressure is up to 102, they're probably dead. The RV cannot rapidly increase its tolerance of pressure. And that's why people die from PEs. But this patient was not even hypoxic. So when you see very high PA pressures in someone that's not even hypoxic, not even tachycardic, you think that this is a more chronic process. So it becomes that you're talking more about pulmonary hypertension rather than acute pulmonary embolism. What's the next step in this case? هلا نحن لما يكون المريض يعني PA pressure is 100 and CVP is 15, the first thing you really want to do is diurese them. Get them euvolemic as much as possible. And this is important that you don't jump straight to a right heart cath, because if you have elevated pressures on the right heart cath, you're not going to be able to say for sure, is this what type of pulmonary hypertension this is. So you want to diurese this patient until you think that they're euvolemic, and then you take them to the right heart cath. In this specific patient, and this is how the reports are generated in our right heart caths. So they mention the right heart cath is performed through the right IJ, significantly elevated right and normal left-sided filling pressures. So RA was 20, and the wedge pressure was 15. So this is, by definition, precapillary pulmonary hypertension. So you have elevated PA pressures, but normal wedge pressures, and elevated mean pressures, and the transpulmonary gradient was 41, and the pulmonary vascular resistance was 12. The patient had a low normal cardiac index, 2.1, cardiac output was 3.8, and this is by FIC, and then by thermodilution, cardiac index 1.8, cardiac output 3.4. And then in patients where you think you need continued monitoring, they leave the Swan in place, and they continue aggressive diuresis and further management of severe precapillary hypertension, pulmonary hypertension. So, and I know everybody knows this, but we'll just discuss very briefly, what is a right heart catheterization? It's when you insert a catheter into the right side of the heart, and it's to measuring the RA, the RV, and the PA, and the wedge. You're measuring pressures, but you're also getting indirect measurements of cardiac output, systemic vascular resistance, pulmonary vascular resistance, pulmonary arterial pulsatility index, cardiac output, power output, and there's some other parameters, and each one is important depending on what you're doing. Personally, we have an Excel file that has all of the formulas already, all the algorithms already entered, so that as soon as we put the patient's information and the measurements that we get from the PA catheter, including the oxygen saturations, it'll automatically give us a cardiac output, cardiac index, and SCR. And if it's this is just if it's a central line. If it's a PA catheter, then we also get these numbers, and it'll give us the pulmonary artery pulsatility index and pulmonary vascular resistance and some other data. But it's important to also understand the equation and what numbers go into it to understand how to troubleshoot it. So what are the indications for right heart catheterization? A lot of times it's because of unclear hemodynamics. You're diuresing someone, their creatinine is getting worse, you're not sure, is this patient having renal function is worsening because they're now volume depleted, or is it because they have cardiorenal syndrome? In patients with cardiogenic shock, it's important for diagnosis and for monitoring. So, someone comes in with cardiogenic shock, you put the right heart catheterization, you do the right heart cath, and you leave in the catheter so that when you make changes, you can see what those changes have become. So if someone has a low cardiac output, you start dobutamine or epinephrine, and you recheck the right heart cath oxygen saturation to get an updated cardiac output and index until you feel like you have a satisfactory output and index. So it's also important for considering patients for advanced options, namely heart transplant or LVAD. So there's a lot of things that might exclude you from getting an LVAD, and this can be easily found from a right heart catheterization. If someone has severe pulmonary hypertension or RV dysfunction, these patients technically don't do well with an LVAD, and they tend to get right heart failure after placing the LVAD. And for those not familiar with the LVAD, it's just a left ventricular assist device. There's the temporary, and then there's the permanent. So temporary left ventricular assist devices, like the Impella device, or even sometimes I guess you could consider a balloon pump as a temporary mechanical circulatory support. The permanent ones, the LVAD, like the HeartMate 3, is pretty much the only one currently being used. Surgically implanted in the apex, and the inflow is in the apex, the outflow is in the aorta. So whenever you're making these decisions, you do need a right heart catheterization to determine the patients that will be successful versus the patients that will not do well post heart transplant or LVAD. Other indications, pulmonary hypertension, like in the patient that we were discussing, and you can also do vasodilator therapy. So, you go in there, you have very high PA pressures, you can inject nitroprusside or a calcium channel blocker and remeasure the pulmonary pressures. And this will help you determine, is this patient going to benefit from certain therapies? And another indication is shunting evaluation. So if someone has an ASD with severe left to right shunting, you can evaluate the volume of shunting. You can also see if this patient is it safe to close the ASD or PFO or even VSD. So in terms of the equipment you need for right heart cath, there's two options, and it really depends on, is this going to be a single going in and out, or is it a leave-in Swan? So traditionally, we use the leave-in Swan more commonly, especially when we expect that this is a patient that's going to need continuous monitoring of PA pressures and oxygen saturations, venous saturations. So it has some drawbacks. It can only be done through a central vein, and it does need a larger introducer. One of the benefits is that it's also capable of thermodilution, which is not the case for several in and out Swans. So this is the Cordis that we use, 8.5 French, single port, single lumen. This is the Swan catheter. It's inserted. This tip has a balloon, and it's always important that when you're advancing the right heart catheter, the balloon is inflated to prevent any damage to any structures. We've all heard of nightmares where people have advanced transvenous pacers or PA catheters without the balloon up. And you need to consider, in a normal person, the RV wall is very thin, and it's very easy to puncture with a PA catheter or with a transvenous pacer if the balloon is not inflated. So always, when you're advancing, the balloon is inflated. When you're withdrawing, the balloon is down. We've also heard of instances where people had the PA catheter wedged, and it's in the very end of the PA artery, the most distal pulmonary artery, and it's wedged, so it's kind of, it's holding that artery, and when they've pulled back, they've torn the pulmonary artery, and that patient didn't survive. So on the PA catheter, the balloon is on one side. على الطرف الثاني, there is the balloon inflation port, and it's usually only about like 1.5 to 2 cc's. The proximal infusion port, which, this one, it ends usually somewhere in the, 15, 20 centimeters from the tip, because this one is supposed to be sitting in the right atrium so that you can have both tracings. You have a PA tracing from the distal port and the CVP tracing from the proximal port. And then there's this thermistor port. This is the one for the thermodilution. So this is as opposed to the in and out Swan. You use a smaller introducer. Very frequently, we'll use these for when we get a consult for a patient that is being evaluated for a liver transplant. And in these liver transplants, they're swollen everywhere. So they always want to be sure that there's no RV dysfunction. And we tend to we don't expect them to need constant monitoring. So we do an in and out right heart cath. We tend to do it from the brachial vein. You can do it from most veins that are big enough. But the advantage is it's a smaller introducer, lower risk of vascular complications. The limitation, though, is that it only has one port, so you tend not to be able to do thermodilution on the majority of in and out catheters. But that's kind of the difference. You need to decide: are you doing the in and out, or are you doing a leave-in Swan? And I apologize. I opened the chat. No one sent anything. But if anyone has any questions, please feel free to interrupt me mid-lecture. We can go through it. So, this is kind of a diagram showing where you're going with the right heart cath. For the majority of cases, we go through the right internal jugular vein. Sometimes we do femoral vein, especially in patients that are going to be sedated. They already have an impella in their groin, so they're laying flat anyways. But we tend not to do them for long terms because of the high risk of infection in groin central venous catheters. So you go through the right IJ, down the jugular vein, subclavian, SVC, and into the right atrium. Then right ventricle, PA pressure, pulmonary artery, and then you keep going until the balloon stops and the waveform changes, and you see that you're in the wedge. This is kind of the trajectory. And the concept is, why are we getting the wedge pressure? It's because the gold standard to determine the volume status is the left ventricular end diastolic pressure. Okay, so we're trying to get the pressure in the left ventricle at end diastole. And the end diastolic pressure in the left ventricle is the exact same pressure as the end diastolic pressure in the left atrium. The pressure is equalized because, as long as there's no severe valvular disease, then the end diastolic pressure in the left ventricle should be the same as the end diastolic pressure in the left atrium. And the same thing can be said about the right ventricle. The end diastolic right ventricular pressure should be the same as the end diastolic right atrial pressure. So this is the gold standard for volume, the left LVEDP. And the left atrial pressure is the same as the PA wedge pressure. When you have occluded the pressure proximally, then the pressure sensor at the tip of the pulmonary artery catheter is sensing this pressure. So this is the easiest way to get the LV end diastolic pressure. And it correlates well with when you do a left heart cath and you do an LVEDP directly remeasuring the LV end diastolic pressure. It correlates very well with this, as long as there's no significant valvular disease or other pathology that could cause this. And this is to get an idea. Right heart catheterizations can be done at bedside, or they can be done in the cath lab. When you have it in the cath lab, it's very easy. You're watching the catheter travel in the direction that you want to travel. But when you're doing it at bedside, you have to rely on pressures. That's the only way you're going to know where you are. So you have to be familiar with the waveforms of the right atrium, and then the right ventricle, and the pulmonary artery, and the pulmonary wedge. And each one is characterized by different things. And it's easy when patients don't have disease, but when the pressures are very elevated, it can be quite challenging to tell. Now, when you're talking about the right ventricular pressure, you're going to notice that right atrial pressure, you get in about 10 to 15 centimeters. As long as you clear the distance of the cordis, then you inflate the balloon. And you know that you're in the right atrium or the CVP, the pressure is no different. As soon as you enter the right ventricle, you're going to notice that you have a very high systolic, not very high, but a significantly higher systolic pressure and a very low diastolic pressure. And then, like I said previously, the end diastolic pressure of the RV should be similar to the end diastolic pressure of the right atrium. And then you notice that this diastolic pressure, in the RV frequently tends to be 0 or very low. Once you're able to float the catheter into the pulmonary artery, you're going to notice that the systolic pressure does not change, but the diastolic pressure has increased, usually to the range of 10 to 15. And when you keep advancing, you're going to notice eventually you're going to feel this. There's a tactile sensation. You're going to feel that you reached a point where the catheter is not going any further. but also you're going to notice that the waveform has changed into pulmonary artery wedge pressure. This is the pulmonary artery occlusion pressure. And you're going to notice that the PA wedge pressure tends to be equal to the pulmonary artery diastolic pressure, as long as there's no transpulmonary gradient. In a patient that has just heart failure, or normal patient, there's no difference between the PA diastolic pressure and the pulmonary artery wedge pressure, as long as there's no remodeling of the vasculature. So, and one other thing to keep in mind, the distance. So if you're advancing your catheter and now you're 35 or 40 and you haven't gotten the RV waveform, then your catheter is probably either coiling in the right atrium or it's gone down the IVC. So if you're at 30, 35 and you don't have an RV pressure, then go back to 15, torque the catheter, try to re-advance it until you get to this point where you're in the right ventricle. And once you're in the right ventricle, same thing. If you're advancing and you're at 50, 60, and you're still not PA, then it's coiling in the RV, and you need to try and withdraw and redirect it. And some patients, as much as you try, you're not. We've had patients where the right heart cath at bedside was not successful. We end up going to the cath lab. If you do enough of them, eventually that's going to happen. Especially in patients with severe pulmonary hypertension, it gets harder to float it. So next is the wedge pressure. If you're at 70 centimeters and you haven't wedged it, then you're probably not going to wedge it. You're probably coiling in the RV or coiling somewhere else. Now look at this tracing and tell me what you think. So we have the EKG at the top. We have the respirometer telling you that patient is inhaling and exhaling. Then you have the CVP, A wave and the V wave. So do you think this is a normal CVP tracing or an abnormal CVP tracing? So, I don't know how these lectures usually go. Feel free to answer. Feel free to just think about it and reflect on your own. And again, if there's anything in the chat that I'm missing, I apologize. Every time I keep it open, it closes as soon as I click on my screen. Okay, so we'll talk about why this one is abnormal. So to know what abnormal is, you need to know what the normal is first. And the normal in this case is, this is the blue one, is the right atrial pressure. The red is the PA pulmonary wedge pressure. And on the right, this is the PA pressure. And the PA pressure is characterized by this dichrotic notch. This dichrotic notch, it comes from, you have the PA systole, it gets this high pressure. And then once it starts diastole, as soon as the PA pulmonic valve closes, this bump is caused by the PA pulmonary valve closing and causing this slight rebound of pressure. So that's the dichrotic notch and the pulmonary artery tracing. The CVP is characterized by an A wave and a V wave. And the A wave is basically correlates with the atrial contraction. You see the P wave comes before it. So the A wave is when the right atrium squeezes, you get this increase in pressure. The V wave is caused by ventricular contraction. So when the ventricle contracts and pushes blood back, that's how you get the V wave. And the normal pressures in the right atrium, 0 to 6. The ventricle systolic usually 20 to 30, and the diastolic is, like I said, the diastolic should be equal to the right atrial pressure. The pulmonary artery systolic should match the right ventricular systolic, and the pulmonary artery diastolic should match the pulmonary wedge pressure, which should match the left atrium and the LV and diastolic pressure. And the mean is below 20. So the diagnosis for pulmonary hypertension is to have a mean pulmonary artery pressure above 20. So going back to our example here, this is abnormal for 3 reasons. Number one, you see that the mean pressure, which is elevated, it's 12. So normal is 0 to 6. you can have normal up to 8, but anything above 8, we say there's something wrong, that this patient's RA pressure is 8. And the other thing you see in this is that there's no respirophasic variation. Normally in a CVP tracing, you're going to have on inspiration, the CVP pressure goes down, and on expiration, the CVP pressure goes up. And you also have a very sharp Y descent in this. So another thing to keep in mind is that for the majority of patients, the CVP is usually half of the wedge pressure. So if it's more than half, you need to start suspecting RV dysfunction. And if the PA pressure gets double the PA wedge, it's normally around double. And if it's more than double, you need to start suspecting pulmonary hypertension. And this is based on data from Dranzer published back in 1999, that the RA to wedge pressure in the majority of people is 0.5. So what about this tracing? This is a pulmonary artery wedge pressure tracing. And we can notice a couple things in this. You see that it's going up and down. Now we don't have the respirometer thing here, but we notice that it's going up and down. So this is the respirophasic variation. And the wedge pressure is 11. So this is a normal PA wedge pressure. There's no significant increase in the V wave. The A wave looks pretty normal, as opposed to this. So what can you see abnormal in this PA wedge pressure tracing? So if you look at the mean pressure is only 14, so it doesn't look too bad. I'm sorry?
لا تمام.
تمام. And again, if anyone wants to answer any of these questions, feel free to answer them, because I'm asking them to see if anyone wants to answer, that's fine. If you don't, that's fine too. But what you can notice in this wedge pressure is that the V wave is very high. So there's a few things that can cause this elevated V wave. Can anyone think of what might cause an elevated V wave from the wedge pressure?
Tricuspid regurg, Hakim.
So that's a good it's a good possibility. The thing is, this is the wedge pressure, so it wouldn't be tricuspid regurgitation. What would it be instead?
بحسب تدقيق عملنا ارتفاع بالبي ويف.
فقط بالCVP tracing. Tricuspid regurgitation will cause a large V wave, and it's an excellent point you mentioned, because there are two systems that are parallel, or actually in sequence, but they're also in parallel. This significant TR will cause a V wave in the CVP tracing, but this is a pulmonary wedge pressure tracing. So this V wave can be caused by significant mitral regurgitation. So whenever you see this large V wave from the CVP tracing, correct, you can think of significant tricuspid regurgitation. But whenever this is from the wedge pressure tracing, this is most likely significant mitral regurgitation. And it's important for a few reasons. Number one, when you're considering repair of the mitral valve, you need to know what the baseline V wave is going to, so that you know after the repair, has it been repaired? If it's surgically repaired, the majority of the time the surgeons put in a fresh new valve, they're working very well. But when you're doing something like a MitraClip, you really depend on the change in the parameters to say, was this successful or not? Because it's not necessarily, you can put 2 clips and have no change in your mitral regurgitation severity. So evaluating the V wave before the MitraClip and after the MitraClip, like MitraClip, the transcatheter pulmonary mitral valve repair, it will tell you, a lot of times you can have the wedge pressure in, and you can say, okay, you put in the clip, the V wave went down from 25 to 15. And from that, you can say, okay, that was a good clip position. Otherwise, if you have no change, then you can always remove the clip and put it somewhere else. So if you see a wedge pressure like this, which number do you report? Do you report the wedge pressure? Do you report the end diastolic pressure? Or do you report the peak V wave? And really what you want to do is actually report all three of them. So you report the peak of the V wave, you report the mean pressure, and you report the end diastolic pressure, because each one of these, depending on the scenario, is important for something else. If you're working on fixing a mitral valve regurgitation, this is the most important number for you, but these are also important. If you're talking about a patient with pulmonary hypertension, then the RV is pumping against the mean pressure. So you really want to report the PA wedge mean pressure. And if you're talking about heart failure, then the most important number is the end diastolic pressure, because this one correlates the best with the LV end diastolic pressure. Tamam, so keep that in mind when you're doing the wedge pressure, and you have very high V waves. You wanna because this really normally the mean and the end diastolic pressure are almost the same, but because you have very high V waves, you're gonna notice that the wedge pressure gets higher. So it's really only in these situations that the wedge pressure is considerably different than the end diastolic pressure. So this is just a waveform interpretation, and like the doctor mentioned, that severe tricuspid regurgitation can cause, the fusion of the C and V wave. It can cause a significant V wave in the CVP tracing only. So if you have severe TR, it's not going to affect the V wave from the wedge tracing. It's only going to affect it from the CVP tracing. And the number you want to report from the CVP tracing, this is the best place to report a number. It's right after the A wave. This is the closest to the end diastolic pressure, and this will correlate the best. And it's most of the time the easiest to reproduce. Pulmonary hypertension. So we know that there's multiple groups, WHO groups for pulmonary hypertension, group 1 to group 5, and you can have a mixed picture. But the main thing to keep in mind is what is the wedge pressure and what is the pulmonary vascular resistance. Because based on these two, you can basically determine which type of pulmonary hypertension this is. So in patients that have heart failure causing pulmonary hypertension, what are you going to find? You're going to find an elevated wedge pressure. The wedge pressure is high because the heart can't pump forward, but the vascular resistance is normal. So you're going to see that in the standard heart failure causing pulmonary hypertension, meaning group 2 pulmonary hypertension, you're going to have elevated wedge pressure, and low pulmonary vascular resistance. So below 2 Wood units. Now, if you have prolonged elevated pH secondary to heart failure, you're going to develop remodeling, and you're eventually going to have elevated resistance. So untreated for long enough, heart failure can cause irreversible pulmonary hypertension. Now, what if you have elevated pulmonary vascular resistance, but you have a normal wedge pressure? This is pretty diagnostic of group 1 pulmonary hypertension. And like I said, so you have an elevated pulmonary vascular resistance over 2 or 3 Wood units, and you have a normal wedge pressure, which is below 15. And, you know, I'm not going to get into CTEF and the other things, but the right heart cath also helps to differentiate these. And here's the important thing. In patients with heart failure, if you have pulmonary hypertension, your mortality increases significantly, your survival. So this chart is, you're defining pulmonary hypertension based on the pulmonary vascular resistance in chart A, and you're defining it based on transpulmonary gradient in chart B. And you can see that patients that have pulmonary hypertension, the solid line is the patients that have heart failure, but their PA pressure is normal. They have the best survival, the survival of standard heart failure patient. But if you have heart failure and passive pulmonary hypertension, meaning the PA pressure is high, but the resistance is low, your survival is in the middle. And if you have heart failure, with the PA pressure is high and the PVR, the vascular resistance is high, you're in the worst shape. Your survival in 7 years becomes 20%. So it's important to evaluate the patients that have heart failure, chronic heart failure, evaluating their pulmonary pressure, because it's very important for diagnosis, for not only diagnosis, but also for prognosis. And it's also an option, a target for therapy. So if someone you're seeing has heart failure and pulmonary hypertension with normal vascular resistance, you need to diurese this patient, get rid of their pulmonary hypertension before they start developing vascular remodeling and permanent pulmonary hypertension. The second thing that we talk about in the right heart cath is calculating the cardiac output. So there's multiple methods in determining the cardiac output. The gold standard is the direct FIC, but that's incredibly inconvenient, and I don't know any lab that actually does that, except maybe in research labs. So the two methods that we have available are the thermodilution method and the indirect FIC method. Whoever is familiar with them, which one do you think is better? So I'll tell you from our experience at Ochsner, and my hospital is a heart transplant hospital. So we do this frequently. Like in our ICU, maybe right now, if I check, probably 10 patients have PA catheters, and we check cardiac outputs twice a day on these patients. Because, if anything starts going wrong, we not want to know about it immediately, because once you start spiraling down, it's hard to recover. But there's two methods for determining cardiac output, the thermodilution method and the indirect FIC. The one that we do at most commonly is the indirect FIC method. The one that's better is the thermodilution. And this is based on a lot of data. This was published probably in 2013. They took maybe 6,000 patients 12,000 patients between Vanderbilt and the VA hospital. And they determined the mortality based on, and they subdivided them based on the FIC and the thermodilution. So if you can see here, the darkest one, both the FIC and the thermodilution are normal. Of course, they have the lowest mortality. Whereas the one that has the slightly lighter color, the FIC was low, but the thermodilution was normal. So look at these people. There is no significant mortality difference between these patients. If you had a low FIC but normal thermodilution, you didn't really have a statistically significant increase in mortality. And these charts are different. This is the 90-day follow-up, and that's 365-day follow-up. Same for both sides. So you can say that, at this point, it was trending towards becoming significant with a p-value of 0.14. But what's important to understand, look at this one, the next chart. This one, the thermodilution was low, but the FIC was normal. But you can see there was a significantly increased mortality in these patients. So the point of this slide is to say the thermodilution independently is better than FIC. When used in combination, meaning if both FIC and thermodilution are low, these patients have the worst mortality. So it's important to do both. We use the FIC at bedside because it's more convenient. Thermodilution, if you were to try and do thermodilution on everyone, it's very resource intensive and not really convenient. Whereas the FIC, all you need to do is draw an oxygen level. So thermodilution, how it works, it's based on a principle, the Stewart-Hamilton equation, that the change in temperature is related. You can determine the flow based on the change in temperature. And what we do is you inject 5 to 10 cc's of cold saline, and the thermodilution, the thermistor catheter, this temperature sensor at the distal tip of the PA catheter, you're injecting from the proximal tip, and you know the distance. So if you can tell the area under the curve from the change in temperature, you can estimate the cardiac output. And we usually do multiple injections, and we do the average, so that if there's any outliers like this red one you see here, we get rid of this one. By the way, can you see انتوا شايفين الماوس تبعي ولا مو مبين عليكم؟
هي صورة حضرتك مغطيتهم هيك.
عفوا؟
صورتك مغطيتهم.
اها طب خلينا نشيل الكاميرا إذا كان هيك بينت.
هيك راح عرض الشاشة على الآخر.
اوكي أحسن. أنا بعتذر، نحن قليل ما بنستعمل التيمز عادة على الزوم. هيك أحسن.
ما في عرض شاشة.
ما في لسه أحسن. آه، أحسن نعمل هيك شير. هيك بينت الشاشة.
هيك ممتاز.
تمام يعطيك العافية. فبس الماوس تبعي لما عم أحركها عم تبين.
إيه تمام عم تبين.
تمام. ف we inject multiple times وبتشوف إنه the ones the outliers we remove them from the equation and you get a cardiac output cardiac index. The thermodilution can be inaccurate if someone has severe tricuspid regurgitation because you're injecting the cold water, but a lot of it is regurgitating back. It doesn't mean it's useless, but it means that you need to take the results with a grain of salt. The same thing with arrhythmia or PVC. If you have one or two bad beats in a row, PACs or PVCs or even AFib, thermodilution loses its accuracy because you have times where your heart rate is faster, your heart rate is slower, and you have to average over all of that. Catheter coiling, or if someone is breathing very heavily because you're making very high changes in the pulmonary pressures. The second option is the FIC method. So the direct FIC is the gold standard for determining the cardiac output. But like I said, no one does direct FIC because to do the direct FIC, you have to be able to measure the oxygen consumption of the body. To measure how much oxygen the body is consuming is an incredibly intensive task. So what we do is we go based on the estimate of the Dahmer approximation, is that based on your body surface area, you're going to consume 125 cc's of oxygen per minute per meter squared. So you're making a very big assumption because some people, their body surface area is higher because they have a lot of muscle. Muscle is going to consume oxygen a lot more than fat tissue, adipose tissue. So in the extremes of body weight, excuse me, in the extremes of body weight, you're going to see that the FIC method is not very accurate, but it's still good for trending. So if your cardiac output is low, then the blood has a lot more time to get extracted from the tissue. So you're going to see the SVO2, the oxygen saturation is low. فالفكرة إنه you're taking the oxygen saturation in the pulmonary vein, the blood that's been deoxygenated, and you're comparing it to the oxygen saturation in the artery. That's the denominator in this. And the numerator is the oxygen consumption. For us at Oshner, we use 3.5 times the weight in kilograms times the hemoglobin. So, and times the constant as well. So this is kind of how the FIC works. And it's important to understand the factors that go into it to understand when you should not use it. If someone has shunting of blood or an AV fistula, these can cause erroneous oxygen saturation, erroneous cardiac outputs based on the FIC method. There's a lot of common occurrences that cause right heart caths to be inaccurate. And right heart cath is something that's very difficult for people, especially and I guess the people that don't do it frequently, because you look at the interventional attendings at our hospital, for example, they're very good at doing left heart cath. They're good at doing structural cases. They don't do the right heart caths very commonly. They only do them when the advanced heart failure specialists are too busy to do them. And you'll find that people will have erroneous measurements. So what can tell you that the right heart cath is wrong? Like sometimes you'll see the wedge pressure is higher than the PA diastolic pressure. That doesn't make sense. You can't have a higher wedge pressure than the PA diastolic pressure because the blood will just flow backwards. The blood flows from the high pressure to the low pressure. So if your pressure is higher in the right atrium than it is in the right ventricle systolic, then that doesn't make sense either. So there's certain PA catheters, if they're done improperly, then you're going to get bad numbers. And you need to understand what's causing it so that you can figure out how to fix it. If there's any air in the tubing, you're going to have a lot of damping. If the catheter is moving a lot with just with the heartbeat, then you're going to get erratic, erroneous measurements. If you're wedging too much or if you're not wedging enough, then these can give you wrong measurements. If someone's breathing way too significantly, this can cause a problem. And the zeroing is also very important, that you have the zero at the level of the right atrium, and it's not too high, it's not too low. You're measuring it, you're zeroing it at the correct level, and you don't move the sensor, because if you move the sensor, you're going to change the numbers. And other things that cause abnormalities in the right heart cath, like we discussed, mitral regurgitation will lead to the very pronounced V waves in the pulmonary capillary wedge pressure. And this can change your mean pulmonary capillary wedge pressure and make it much different than the end diastolic pulmonary capillary wedge pressure. So that you have to keep that in mind. Thermodilution, like we discussed, it can have some pitfalls, and same thing for the indirect FIC, can also have inaccurate cardiac output. And these are some important equations that, again, it's important to understand the concept of them. Honestly, most people don't memorize them because you can just save these equations and these algorithms in an Excel file and you just input the numbers and it calculates it for you. But again, it's important to understand the concepts that go behind them. And each one of these has a clinical relevance. Whether it's the pulmonary artery pulsatility index, this is good for telling us that the right ventricle is failing, especially in a patient that just got a ventricular assist device. So the PAPI, we call it, pulmonary artery pulsatility index, is good for that, and it's good for estimating mortality post-LVAD. Same thing for pulmonary vascular resistance. And the cardiac power output, we also use it in our shock calls. This is just a very basic diagram to talk about cardiogenic shock. That's characterized into 4 possibilities. You're either warm and dry, warm and wet, cold and dry, cold and wet. And this is all based on your cardiac index. So the cardiac index is your cardiac output divided by your body surface area. So that's using the index is a way to try and normalize for the extremes of body weight. But again, it can be erroneous in the extremes of body weight. So if your cardiac index is low, your extremities are going to be cold and you have a low output state. And for these patients, you need to start them on inotropes and reduce the afterload, or possibly even mechanical support device like an Impella or a balloon pump or an LVAD. And then the second parameter is the wedge pressure. So if the wedge pressure is low, then you don't need to do anything, or sometimes you may even need to give some fluid. If the wedge pressure is high, you need to diurese these patients. One of the biggest determiners, the biggest things that determine the patient's long-term outcome is not necessarily what the wedge pressure is, it's the inability to decrease the wedge pressure with diuresis. It's not necessarily how high the wedge pressure is. It's after diuresis, were you able to get the wedge pressure back to normal? If you were able to get it back to normal, these patients have a better outcome than the ones that, even with extensive diuresis, you were not able to improve the wedge pressure. So here's another scenario that we see very commonly in the States. Maybe it's not going to be as common in Syria. Old ladies, especially women, that have dyspnea on exertion, and they get extensive evaluations, normal hemoglobin, normal echo, normal this, normal that. Sometimes the echo can pick up on this, but not always, depending on the echo reader and depending on whether or not they got a good image. And then they get a right heart cath, and that's normal too. What can you do to say 100% this is not a cardiac or a pulmonary hypertension problem? You can do one of 2 things. The first is an exercise right heart cath. So while you're doing the right heart cath, if you have very high suspicion that this person has either diastolic heart failure that's exercise-induced or exercise-induced pulmonary hypertension, you do the right heart cath and you have your catheters in place and you make them exercise, whether it's jumping jack, well, not jumping jacks, they have to be laying down, whether it's a treadmill on the legs, bicycle, or a bicycle with the hands. You need to do some form of exercise that makes their cardiac output go up. And normally the cardiac output goes up about two for every I think it's like 1 liter of cardiac output, the wedge pressure should only go up by 2. In patients with heart failure, preserved ejection fraction, diastolic dysfunction, you're going to notice that the PA wedge pressure goes up much higher than the cardiac output goes up. So if someone has exercise-induced pulmonary artery hypertension, that means their mean pressure goes above 30 and their pulmonary vascular resistance is above 3 Wood units. That's the diagnostic criteria for it. If someone has heart failure with preserved ejection fraction and exercise-induced diastolic dysfunction, the wedge pressure goes up to 25 and persists there for 5 minutes or maybe 2 minutes, because these pressures, they go up and it takes the heart a while to get the pressure back down to normal. The other alternative is doing a fluid bolus. This is a lot easier because you don't need as much equipment. It's not as good, of course, because it's not as physiologic as exercise, because, you know, the patient is saying they have dyspnea, shortness of breath on exertion, not shortness of breath when you give them 500 cc's of fluid. But it's nevertheless, if you don't have the equipment for exercising the patient, you can give a fluid bolus of 500 cc over 5 minutes. And if the wedge pressure goes above 15, then this patient has diastolic dysfunction. And this is assuming that their systolic function is normal. When do you want to kind of consider this? Is when you look on the echo and you see a reduced E prime velocity, mitral annular E prime velocity. So I don't know if anyone has seen the new diastolic dysfunction, the guidelines on determining diastolic dysfunction. Decreased E prime velocity alone is enough to say that the heart does not relax well. So if you have someone that has dyspnea on exertion and the E prime velocity is below 7 on average, or around 7 on average, then, because normally it's 7 for the medial, 10 for the lateral, but if both of them are below 7, you need to consider patients that have dyspnea secondary to diastolic dysfunction. So common scenarios where we do right heart caths, a lot of times we'll have patients that have a kidney transplant and they're coming in with volume overload and their creatinine is getting worse. And the transplant nephrologists, we always disagree with our colleagues. We think that the patient needs less fluid. They think that the patient is diuresed already and dry, and that's why the creatinine is worsening. So the right heart cath really helps support our opinion, or, you know, I guess sometimes it can also prove that we're wrong, but I think most of the time it ends up showing that we're right. Because keep in mind, the kidney transplant patients, they're going to be very, very cautious on the side of elevating creatinine. Other times we see in patients, outpatient chronic heart failure patients with dyspnea, but on the JVD exam, it's normal. These patients get a right heart cath because this can be either that the dyspnea is caused by something else, or that this patient is having dyspnea because of elevated wedge pressure and pulmonary edema, but normal right-sided filling pressures. And if you're not able to unload the left ventricle, this is also a bad prognostic sign. And like I said previously, any patient that's on inotropes or mechanical circulatory support, they need to have a PA catheter. And that's the end of the talk. Thank you for your time and your attention. Please feel free to ask any questions. Was anything not clear on the right heart cath? I know I went a little bit fast. I tried to get everything in. Do you do frequently right heart caths in Syria? تعملوا right heart cath ولا مو كتير؟
نادر جدا، يعني يمكن مرة واحدة انعملت بحمص.
عن جد؟ نحن بنعملها يوميا هون الرايت هارت كاث، يعني يوميا الهارت ترانسبلانت تيم. هلا طبعا هن they're following their chronic heart failure patients، فهن بالكاث لاب بيعملوا يمكن 4 أو 5 باليوم. والinpatient the ones اللي عندهم cardiogenic shock وعم نحط لهم دوبيورامين هدول نصا عندنا الرايت هارت كاث and we're just كل أسبوعين بنغير لهم إياها. بس it's a very useful tool especially in these scenarios.
هي
يعني
يمكن
بنصح
لأنها غالي شوي بس هي والسوان جانز يعني.
هلا السوان جانز كاثر يعني هي هاي الفرق بالسعر. طبعا البريفرال ones بتكون أرخص لأنه ما فيها هاي الثيرمال سنسور، يعني فقط فيها pressure sensor وبالون، فبتكون أرخص. هلا عن سعرها والله أنا ما بعرف عن أسعارها، بس الحقيقة أغلب الانفورميشن اللي ممكن تاخده من الرايت هارت كاث الأكو can potentially get it. ممكن الأكو إذا كان good views وطلع عندك يعني مثلا pulmonary regurgitation jet، ممكن في محاضرات اونلاين موجودة عن ال right heart cath by echo. صراحة كتير مفيدة وبنصح تشاهدوها لأنه right heart cath is the invasive gold standard بس the echo can be just as accurate as the right heart catheterization. فكتير بنصح باستخدام الأكو to get some of these parameters when they're available. تمام، شكرا على وقتكم وفرصة سعيدة. وأنا أنا ما حطيت أرقامي بس اللي يعمل الأورجنايزر عنده إيميلي وعنده رقمي، إذا حدا عنده أي سؤال فيني ساعده فيه أنا حاضر. وشكرا كتير على وقتكم. وهدول references
شكرا
كمان.
لك دكتور.
أهلا وسهلا، مع السلامة.